Anusha, we see mothers develop what we call postpartum depression. Is it not normal for a mother after giving birth to have postpartum blues?
Well, I think that's an important point that you make, Dr. Ron, because postpartum blues are actually common for only the first 72 hours to about a week thereafter. And it's a result of a rapid decline in the hormonal surge that happens post delivery. I think the problem is that we don't recognize depression versus postpartum blues. And we often think that, oh, it's normal, mums go through this, we'll get over it. Postpartum blues is something very specific. So often the mums might have an irritable mood, they might feel restless, have some anxiety, feel a bit overwhelmed, maybe a little bit moody, we'd say. But they very quickly are able to recalibrate. The problem is if we allow these symptoms to persist, so we start to worry when the symptoms last longer than 2 weeks, for example, then your rates or your risk of postpartum depression seem to exponentially increase. And that's a problem. In fact, 20% of women who do complain of postpartum blues run the risk of developing a full-blown postpartum depressive episode. So we really need to be careful about sort of just saying, well, it's just part of normal postpartum blues. So I think that's the fundamental difference. Something that lasts longer, and especially when the moms start to present with more significant symptoms, not just the sleep difficulties which we expect with the new baby, but really feeling sad, not having that pleasurable experience with the baby. They might say, look, I just feel overwhelmed, but I'm just not enjoying this anymore. They have difficulty in attaching to the baby. They might say, why am I not feeling like I should be, massively in love with this baby, as all new mothers are? And they complain of extreme fatigue, sleep difficulties that are not just as a result of a baby being up the whole night, but really not able to fall off to sleep, not able to maintain the sleep. And really, that's when we start to worry that this is more than just postpartum blues.
Are there moms who are at a higher risk of developing a postpartum depression?
Absolutely. One of the most major risk factors is a mom who has a previous history of either a mood disorder or a mental health condition or a family history of depression. Often they're at highest risk. And also, surprisingly, the younger the mom is, the more they are considered at risk for a postpartum depression. Of course, it can affect any mom, but there are certain women that find themselves more vulnerable. And what we don't talk enough about in terms of risk factors are moms who are often alone. So you may physically be with the partner, but not really having that shared responsibility or support. Obviously, moms who are experiencing numerous psychosocial stresses, so financial stresses, economic stresses. Also, we don't talk enough about at-home domestic stresses in terms of intimate partner violence. A lot of women are struggling in silence, and that immediately increases their risk for postpartum depression.
How do we treat or support the mom in a postpartum phase?
So again, if it's something like postpartum blues that we're worried about, it usually resolves, like I said, with just supportive, empathic care. So kind of, sort of easing the mom into it. When we're talking postpartum depression, then there are two modes of treatment which are recommended often. Psychotherapeutic interventions work really well, especially in that early phase. But we also mustn't be afraid of using medication. So medication is really effective, it works quickly, and it helps resolve problems. Obviously, the combination is the first prize. But depending on what the access is, in terms of most moms may not have the flexibility to attend psychotherapeutic support sessions. Often, obviously, given with the new telepsychiatry options, that's a better option now, that moms can, from the comfort of their home, engage with the psychologist. But medication is very effective for postpartum depression.
How long must the patient stay on medication?
So I think we need to look at the other factors that help support or resolve the condition. So if the mum is able to get support in terms of additional help for the baby, able to get some intervention for the relationship with their partner, then we are able to get away, I would imagine, with fewer sessions psychotherapeutically. But if a mum is really struggling without support structure, she may need a longer term treatment. In terms of medication, the fear always is, am I going to be on this for life? Is it going to affect my baby? The truth is that it's response dependent. If a mum has not had a previous psychiatric condition, hasn't had depression that's difficult to treat, then a short-term 3 to 6 month treatment of an antidepressant or with an antidepressant can be very effective. I was wondering if, while we're talking about moms being worried about it affecting the baby, I think that there's a lot of misperception out there in terms of medication causing, sort of irreversible damage to the baby and affecting breastfeeding. We have really good guidelines and support structures that give doctors and therapists advice on when the mom should be breastfeeding, after or before they take the medication, when they express milk. It's also important to remember that moms become depressed even in pregnancy. And medication here can also be really effective because ultimately it's about the risk versus the benefit. So what a baby needs is a well mother. And if a well mother is only well on medication, then there are suitable and safe options of medication that aren't such a big risk to the developing brain.
So if the mom starts feeling better and feeling well, it's not up to her just to stop the medication.
No, absolutely not. And in fact, it can be quite dangerous because immediately withdrawing medication without a doctor's advice, without a staggered withdrawal of it, can be quite dangerous. And we also don't know what the risk of relapse is for a mum, depending on her past history. But a doctor alongside a therapist can very easily transition a mum into not needing the medication anymore and perhaps just relying on psychotherapeutic support or social support. But I think that the viewers need not be afraid of getting dependent on medication or not being able to be off it. I think alongside a doctor, it can easily be managed.
Yeah, we've now looked at the mom. What does the baby need?
And thanks for asking that, because we often only fixate on how, for example, drugs damage babies or can have effects on the developing brain and things like that. And while that's true to a certain degree for certain drugs, we also have to remember that babies need more than just being looked after physically. So what babies need is consistent, good enough mothering. And good enough mothering means that mothers don't need to be well 100% of the time. They need to be mostly well, consistent, and nurturing in the care. And at this point, I think it's important that we talk about most moms needing to return to work, even if they're not mentally unwell, and they are having other commitments, they have other children, and very often we are having to employ services such as nannies or domestic help, or we're looking at the dad, or we're looking at relatives, grandparents, and all of this is actually okay, because all we refer to them as is secondary caregivers. And all a baby needs is for that secondary caregiver, whoever it is, to be consistent, to be nurturing, to provide the care, the kind of care that's predictable. And so when the mom wants to look back and say, well, am I really not being a good mom because I'm away from the baby? We need to remind them that it's actually not the quantity of time that you spend with the baby, it's the quality. And most moms spend good quality time with their babies, either after work or before, or in the middle of the day. And even though they may not be present the whole day through, as long as they are giving the baby an opportunity to connect with a secondary person, that baby's going to be okay.
So they don't need to feel guilty.
There are moms who may spend 24 hours a day with the baby and not have the kind of quality care that that baby needs. We often say, what makes a baby thrive? What makes a baby thrive is that nurturing, sensitive care. And that doesn't come from stuff. It doesn't matter how expensive the toys are or, sort of who you're getting to engage with the baby. What is important is that when you are with that baby, you are emotionally present with that baby, that you take some joy in that engagement and that it's reciprocal. And you will notice very early, babies socially start to engage with their parents from as young as 2 to 3 months. So that reciprocal engagement is what's important. And that just comes with quality care, not quantity of care.
Is that not true of all relationships? Even the dad need that same kind of care.
The mom didn't produce the baby on her own. And we know that, and in fact, an important thing for us to talk about is dads also can get postpartum depression. So we need to be able to realize that both parents, even if they are same-sex parents or they are heterosexual couples, that both are important in terms of quality of care that's going on. So when we ask moms how you're doing, we need to ask moms' partners, if they're there, how they're doing as well, because both of them have an effect on the baby.
Thank you, Anush. I think this was excellent. I feel like I could engage and keep on talking to you the rest of the afternoon, but they've limited us here.